you. My name is Balkozar Adam. I am with the University of Missouri Columbia, and it is a pleasure to be here. This is the first time for me to attend this meeting, and I am really impressed. Wonderful work. Thank you very much for the organizer, and special thanks for Dr. Abbasi. So today I'm going to talk about treating American Muslim youth, a culturally sensitive approach. So today my goal is to understand the impact of culture and religion on the mental health of the youth, and review the DSM-5 culture formulation and culture formulation interview, and to apply some principles from the American Academy of Child and Adolescent Psychiatry practice parameter for culture competence in child and adolescent psychiatry practice. So to avoid discussing a patient that I saw, and because of confidentiality, I thought I would present a patient that was published at the Journal of the American Academy of Child and Adolescent Psychiatry in June of last year. I will call him Harun. He was a 15-year-old boy. The family came from Sudan 5 years earlier. And then he was complaining of talking to people that are not there. He was having problem sleeping. He could not go to school, and he was agitated easily. So the family thought that maybe he has dehydration. So they took him to the emergency room. The emergency room ruled out any medical reason for his condition. The family said they would have been praying for him. So initially the family were quiet and expressed spiritual concerns. One of the physicians was Muslim, so he asked them about jinn, and our presenter in the session before was talking a lot about jinn, but if anybody would like a description of that, I'd be happy to describe that. So when he talked to them about that, they became more comfortable, and they told him there are other family members that were afflicted with jinn. So the family agreed that they start him on risperidol, and they would also agree to continue praying for him.
Big green bar.
It is here. So after 3 days, he started feeling better. He said that he smoked unknown substance that was given to him by a new friend. So the family felt that that friend made him more vulnerable to the effect of jinn. Instead of maybe the thing that he smoked made him psychotic. So anyway, they agreed to continue medication treatment, continue outpatient treatment, and he did not use substance. So I'm going to discuss some of the instruments that we use when we deal with adolescent youth Muslim. It also can be used with other minority children. It's important that we understand the culture and not overgeneralize. You see a lot of Muslims here. They are not the same. So the culture formulation outline was introduced in DSM-4 as a way to see the effect of culture on the mental health presentation of the patient. Then DSM-5 came and updated the outline and added the culture formulation interview. It is a set of 16 open-ended questions, and it was field tested and found to be effective both for the patient and for the clinician. Very useful. So the revised outline for culture formulation called for assessment of 5 factors. First one is cultural identity of the individual. So for me, myself, for example, I can say I am a Muslim psychiatrist, I am a US citizen, I am of Arab background, I am a mother, grandmother, I am bilingual, I also like shopping. And then the psychosocial stressor and culture feature of vulnerability and resilience. For this boy, he was not going to school, he was using drugs, he has a friend who was a negative influence on him. But he has a family who was supportive and he was willing to take medication. And then culture feature of the relationship between the individual and the clinician. We don't see people that are exactly like us. So even if they are closer to us, it's hard. I'll give you an example of a patient I treated. He was a refugee adolescent. And I was trying to build a rapport with him, so I was talking to him in Arabic. He was from Syria. So I was asking him about symptoms of depression. So I asked him, do you cry easily? بتعيط? And he said yes. I have a refugee worker with me. She understands that the way that they say cry in Syria is different from the way I expressed it. So she said, wait a minute, what do you mean by you cry easily? He said, I get upset easily and I yell. So I was thinking about that, maybe this is a symptom of depression. It can be, but it's very different. So then you combine all this to have an overall culture assessment. So it's important to understand the religious and the culture of our patient when we treat them. At this age, Muslim youth are labeled, judged, attacked, discriminated against, and victimized. They get it from both sides. They are suffering from depression and anxiety, PTSD, and other issues. When there is a terrorist attack perpetrated by somebody who has a Muslim name or claim to be a Muslim, they do not have enough time to grieve for their country. They found that they have to immediately spring in condemnation mode. No, this is not Islamic. So they want everybody to know that judging Islam on the basis of a few Muslims is like eating a rotten fruit and judging the whole tree. To summarize, culture formation interview is an operationalized tool to help us determine the impact of culture, race, ethnicity, and religion on our patient. It's quickly becoming the most popular evidence-based tool for culture assessment. The idea is that the patient talk about what is going on with him. And that can be used not only with minority patient, but with every patient. And not only when there is a difference in the culture between the clinician and the patient. This is because all of us bring to the treatment setting our own ideas, values, expectation, which may affect the way we treat that patient. So the culture formulation interview is three components. One is the core component with the patient, another with the informant, his family, and the third one is there are 12 modules online. So the core component is 16 open-ended questions that are divided into 4 domains. One is culture definition of the problem. You can ask the patient, how would you describe what's going on to your family and to your friend? And then culture perception of cause, context, and support. This family, they thought that the reason for his problem was he was affected by jinn. Culture factor that affects self-coping and best help seeking. So we can ask him, what did you do on your own to help yourself with this situation? And what other support and treatment did you seek in the past? And then culture factor that affect current help seeking. What do you think you need now? So I cannot go back, but I'll tell you that informant version is asking similar question to the people that know that patient. So like his family, his friend, his caseworker. So we get a different result are online 12 modules that ask in-depth questions. And these in-depth questions can give you more ideas. You can use some of this formulation modules alone or as part of the culture formation interview. And I want to mention there are two specific modules that can be of help to us. One is addressing children and adolescents, and one is addressing refugees. So this is how the first page looked like of the culture formulation interview. So this is a quote from the American Academy of Child and Adolescent Psychiatry, practice parameter for cultural competence in child and adolescent psychiatry practice. I really love this quote. So the cultural values and belief can help or hinder care. So there are 13 principles in this culture, in this practice parameter. I will mention about 8 of them. So the first one, the Muslim patients, they are diverse. They have different backgrounds. So it is important for the clinician to identify and understand barriers. Maybe there are economic, geographic, insurance, a cultural belief that can keep them from seeking treatment. So studies showed that non-Hispanic white families are twice as likely to seek mental health treatment compared to other minority. Minority are less likely to continue outpatient treatment or get more services like day treatment, case management, therapy. Maybe they will do medication for a little while. Minority often wait till the situation is really a problem. And they may have more issues with economic, geographic, and insurance. And the stigma is really difficult for the minority and Muslim patient because they are already minority. And now they have mental illness, that's too much for them to handle. Many times the troubled behavior is identified by the school or the court, not by the family themselves. Then principle 2 is the importance of language in the assessment. Psychiatry is language-based communication. So if you are dealing with an immigrant who is not fluent in English, you will not be able to really get a good history. And then it's important to have translator and interpreter. So when you have if you don't have that, it might lead to misdiagnosis and adverse clinical effect. So when you have a translator, ask that translator to tell you exactly, literally, what the patient was saying. And then after that, you can tell him, okay, so he used this idiom of distress. What does that mean? Is his behavior in this culture appropriate, or is this different from this culture? So, principle 4, clinician should be cognizant of cultural biases. So, stereotype and prejudice are all bad, and they affect the clinical care in a negative way. So, if oftentimes there are subconscious thoughts that creep into our action. So, if we resort to stereotype, it will lead to wrong diagnosis and wrong treatment and not good quality of care. We have to also understand the cultural difference in developmental progression, idiomatic expression of distress, and symptomatic presentation of different illness. Other people mentioned how Muslim patients can present with somatic symptoms that say, I have depression. Culture differ in their motor, language, cognitive, and social development. So you can see in many Muslim families that they want their children to stay with them till they finish their education, till they get married, till they get a job. So people might say, that boy is in his 20s and still at home. He has problems. So if taken out of context, it can lead to misdiagnosis. If there is culture syndrome, like maybe a person like what we discussed, that he think he was afflicted by jinn, and the family tells you, we need to do something called zar, or exorcism, get this jinn out. You might want to contact another clinician who is familiar with that culture. So it's important to look at history of trauma. So pre-immigration stress include like they has been persecuted or they were in war, migration stress, the boats that are sinking in the Mediterranean, the smugglers that are coming and taking advantage of abusing these people, and additional stress of prejudice and discrimination. However, studies show that if the person is from European origin like Bosnian, they adjust easier in this culture. So effect of stress in adults, you can see domestic violence, criminal activity, family fragmentation, and in children, especially those who are victim of wars, you see conduct disorder, aggression, sexual acting out, substance abuse, depression, and PTSD. Clinicians should evaluate addressing treatment, acculturation level, acculturation stress, and intergeneration acculturation family conflict. So the youth, the Muslim youth, has to learn how to balance the culture at home and the culture at school and the environment. The best outcome is bicultural identity. I am American Muslim, I am American, Arab American, I am Pakistani American, I am African American. So you get the support from both cultures. Other outcomes can include marginalization, assimilation, separation, and negative identification. So it is important to address this acculturation stress in therapy. Principle 11, clinicians should support parents develop appropriate behavior management that is consonant with their cultural values and beliefs. So studies show culturally adaptive family intervention program were superior to non-adaptive version. If it's important for the child to pray before bedtime, encourage that. Advise parents not to use any techniques that can be incongruent with Western culture, especially against the law. If they hit their kids, for example, that's how we used to do it. It cannot be done here. And then parent-child boundary issues. Many times, the children know the culture better, know the language better, so they get raised to a parentified role. They are talking for their parent, communicating with their parent, and that affects the parent-child relationship. So the last principle is clinicians should identify ethopharmacological factors that can be affecting the medication response and side effects. So we always have to consider biological and genetic factors to combat health disparity. And we always need to look at different patterns of medication metabolism and activity and the risk of side effects. Studies showed African American experience less response to SSRI, and they experience more problem with tardive dyskinesia and extraparental side effects. Asian American have lots of slow metabolizer, and they can experience the American doses of medication we give them to be too strong. Keep in mind for Muslim Ramadan, they are fasting, so you give them the medicine maybe twice a day, not midday. They might not want medicine that have alcohol, and they might not want medicine that have gelatin. So with that, I would like to stop. Thank you very much.
So Assalamu alaikum. My name is Sameera Ahmed, and I'm from the Family Youth Institute. And it'll be a nice segue from the previous presentation, because while we were initially talking about from an individual approach, what I'm going to do is kind of take it from a more of a public health approach. And when we talk about, if we think about promoting Muslim youth development, what are the things that we need to consider to have that mass impact? Because many of us are coming for different reasons, maybe as researchers, clinicians, parents, community activists, and while it's important to consider the individual, if we want to have that mass impact, it's really important for us to talk about and think about on a larger scale of impact. So what I'm going to do a little bit today is, let's go a bit forward. Okay, thank you. So, while many of us are trained from kind of the medical model and looking at the individual, one of the things that we need to think about is, if we look at it from a public health model, right, the impact of the work that we're doing may be far-reaching. So public health, for those of us who are not as familiar with the public health model, that helps us understand what are the different factors that impact, what are the different human factors, what are the factors that can promote development, what are the factors that can harm development, what are the things in the environment that can make a difference, and really suggest and consider possible interventions. Public health takes more of a population approach as opposed to individual approach. And one of the things that I want to do today is really kind of present a model that the Family Youth Institute is using to really start addressing this issue. Now, don't we just scare people here? So this is the developmental contextual model proposed by Richard Lerner's lab at Tufts University, and many of you have heard me present about this beforehand. But when we think about development, if we want to promote Muslim youth development, we need to understand what's going on for them. How is their development happening? And for us to really consider that there are really four main factors that can really impact what happens to them. And, part of it is the individual factors that were mentioned earlier. What's going on individually, what's going on in their temperament, their mental health and well-being, their health. What are their strengths, what's their personality? All of that has an impact on the individual. Similarly, those in their environment, their parents, their relationship with their parents, what's going on with their parents, their mental health, their well-being, their situation at work, what is going on in their marriage, what is going on into the school environment. All of those factors are factors in their environment that need to be considered. Third, we also need to consider and realize that there's a bidirectional impact, meaning the environment has an impact on the individual, but the individual also has an impact on those around them, right? Similarly, all of this development is happening within a larger context, a cultural context. No one can deny the situation in our country has changed dramatically in the last 5 years. Right? So that socio-cultural political climate also has an impact on the individual's development. And then also realizing that there are developmental changes, and those changes happen over time. And so these factors need to be considered when we think about promoting positive youth development. Now, I'm not going to go into the theory and details of what that means for Muslim youth. We did write a report called the State of American Muslim Youth Report. And in that, it goes into great details, probably 46 pages of details of what this means for Muslim youth. So I do encourage you to go to our website, fyi.org, and download that. It's really available to get a better understanding of depth. What I want to do today is really talk about how to apply that, right? And so as we see here, that if you look at the factors that we could probably have the greatest impact on, we see that you can have the greatest impact on the child and the factors that impact them. At the same time, parents or individuals that we can really connect with and talk to, and earlier mentioned about, well, what are we empowering the parents with? How are we helping them, right? And really kind of think about, of these two areas, what can help them the most. And we think, well, mental health is really important. Their health and well-being is important. And so what we do is we really focus on 4 areas, right? We focus on the mental health and well-being of the individuals within the family and within the community culture. We also look at marriages and how do you strengthen marriages, because if you have strong marriages, that can help strengthen positive youth development because you have a system to help promote the young person's development. Similarly, we want to help and empower parents because if they're using effective parenting skills, then they're more likely to be able to parent and empower and develop and promote their child's development. And then finally, we also need to consider what are the issues and nuances that impact children, specifically in terms of the different variations and things to consider. And so our focus areas are these 4 areas. Now, when we go back to this model, we also realize that there are many different intervention points to consider where we can actually have an impact. So we have the individual, the child, the parent, the social network, their peers. You have the school network that can also have an impact and be an intervention point. You have the community, the masjid, the neighborhood community. And you have society, all the different policymakers that decide what happens for, what funding is available, what's not available, what are the programs available in the community. And so we need to consider that if we want to have that impact to promote positive youth development, we need to partner with all of these individuals so that we can simultaneously have that impact to promote youth development. And so when we look at this, we partner with multiple different individuals, right? So obviously the parents and young people, but we need to reach out to their mentors. We need to reach out to their educators because they are in school for a good 6, 8 hours depending on their age. We need to work with health professionals who are sometimes the first individuals or the gatekeepers who can refer individuals to the need for mental health, as well as other services. Community leaders who might be the gatekeepers to allow programming to happen. Policymakers, all of those are individuals that need to be on the same place to help promote youth development. And so we engage all these different individuals. Now, in terms of understanding the intervention points, the focus areas, then we need to also think about, okay, well, how are we going to promote youth development? And so I'm going to kind of outline quickly 6 steps that we want to do, and then I'll try to go into a little bit more detail. And the idea to share this model is, one, to understand and potentially inspire other organizations who are working to help promote youth development, but also to elevate the conversation about youth development and what do we need to do to promote and strengthen our young people. So first of all, we need to identify the problem. What are the problems, what are the issues? And really take more of a community-based approach. One of the issues that Dr. Mohammed mentioned on our first day was really who's setting the agenda, and what are the issues that need to be discussed, and why are we discussing it, right? And then what are the different contributing factors? So what are the causes? Let's do the research, and then take that research to understand what actually works as opposed to our anecdotal evidence, and really take that information. But it's great to have the research, and it's great to have the solutions, but the problem is, how do you educate the individuals who need to be empowered with that information? So really translating that material in an accessible form for the different audiences that you're working with, who are your partners in change, right? And so really what we have to do is then translate according to audience. And once you translate those resources, then you need to implement that and get that out. And there are multiple different steps we need to consider for behavior change to happen for the different audiences. And then once you've done that, does it actually work? Do we have any evidence that what we set out to make a difference? And did it actually have that impact? And so the importance of impact analysis, program evaluation, to see if you are actually making that difference. And so when we think about step 1, what is the problem? What we tend to do is we take numerous different approaches to understand the problems from the community's perspective. So really engaging community organizers, imams, leaders, community feedback, individuals reaching out to us reaching out to the individuals. We use a variety of different approaches to get an understanding of what are the problems and issues facing our families, particularly in terms of the area of promoting Muslim youth. And so oftentimes we'll go to conferences and the conference organizers will say, talk about this. Well, when we find out from the community that people are asking about this question, there needs to be a disconnect. I mean, recently I was at a really one of the major conferences in the US, and almost majority of the questions asked by youth were related to pre-marriage and the marriage process, right? When we had presentations on marriages, the number 2 question asked was about adultery. How do I deal with that? My spouse is cheated, this has happened, what do I do? Again, these are not the issues that we are thinking about, but this is what the community, the individuals are telling, we need to understand how to address these issues. And so it's really important to have that process where we understand what is the problem from the community's perspective. And then we do research. Original research focused on the Muslim community. So when you think about youth, the Muslim youth are not a monolithic community. We have specific nuances that need to be considered in terms of convert youth, Black Muslim youth, immigrant youth. What are the issues in terms of risk behaviors? And so really kind of diving deep into these different issues. What are the issues of identity and how does it differ depending on the different multiple identities you may have? And then also in the different other areas in terms of parenting, marriage, and mental health, because they all interact and have that impact on young people. And so this is some of the research that we're doing ongoing, and some of us presented this weekend at the conference. But that research then helps us inform us in terms of the solutions. For example, we know there's preliminary evidence for the effectiveness of positive youth development for Muslim youth. So then how do we take that information in terms of, well, we know this is going to be most effective, how do we then move it to translating it to be more effective to the different audiences who are our partners? And so we realized that we need to kind of take that information and provide videos, infographics, workshops, articles, depending on where people are at, and meeting them based on their need and the audience that we're talking about. Most people are not going to read peer-reviewed research articles, but the academics will, the researchers will, and that will inform their work and the clinicians' work. Parents, on the other hand, may need more specific information, short, 5-minute, 2-minute, 3-minute segments. And so realizing that we need to adjust our information accordingly. And then once we develop those resources, we need to disseminate and educate people. And so realizing that there are multiple different platforms that we need to use, many different gatekeepers that we need to disseminate that information out to, because that will have the greatest impact. And so again, we disseminate to the different massages, researchers, schools, policymakers, so that we can have that impact. And that brings us to actual behavior change at the community level. And so, while most people may not know the issues of facing Muslim youth, they're at the pre-contemplation stage, we then want to help them become more aware of what needs to happen, what are the issues. And so we move them from the pre-contemplation to the contemplation area. And we're starting to kind of start putting in the seeds of change. And that's where you move to preparation. And from preparation, then we use that kind of seed to kind of propel them towards action. And we realize that people get tired, and from there, you kind of help maintain that action and change, and then realize that relapse will happen, and help them move back in. And so, realizing the cycle of change, we have developed our resources in such a way that it can have that impact. So we start off with the infographics, and that's the purpose of to raise awareness of the issue, and then we immediately connect them to the actual research articles that people are interested in knowing about. Most people won't read it, but we recognize that infographics will definitely raise awareness. We move that to the videos to inspire the people to change. We then kind of bring that into the workshops to really focus on skills building, and we have over 30 different workshops on different topics. But then to sustain that change, we provide them regular information, daily articles, and detailed, greater in-depth information through the research reports that we develop. So what does that look like in terms of actual implementation? So, like I said, initially the first stop is infographics. We raised awareness. We've done the original research. We found the solutions. We know what's going on. Let's raise awareness and provide these infographics. And so this is just one of the infographics we have. If you want to see the other infographics, we have on alcohol use, drug use, tobacco use, other risk behaviors, bullying, and all that. These are what we know from the research that we've done. Most of it is what we've done in-house. And what are the things that we need to do to actually bring about change? But the real focus of this is just to raise awareness, right? Then we have these videos. And I'm going to play the video right now, and that's meant to inspire change. There's no sound.
Alcohol, tobacco, and premarital sex among Muslim college students. Parents must wonder how they can prevent these challenges from happening in the first place. The first step to prevention is understanding the problem. There are many reasons why youth engage in risky behaviors. Teens with low self-esteem are more vulnerable to peer pressure. Youth who do not feel loved by their parents search for it in the wrong places. But can parents really prevent children from engaging in risky behaviors? The answer is yes. Research has shown that parents have the greatest influence over their child, and this is also the relationship families have the most control over. So what does research suggest parents do to prevent these behaviors? 1. Frequently hug, kiss, encourage, and praise your child. This will increase their self-esteem and shows them that they matter to you. 2. Encourage open two-way conversations with your child. Avoid lecturing them and discuss their daily ups and downs. This will earn your child's trust and improve their decision-making skills. 3. Carefully monitor your child's activities and whereabouts. Get to know their friends by taking them to and from after-school activities. Also invite their friends' parents to your home. Monitor their online activities, such as websites they visit, and use FaceTime when they're out with their friends. 4. Avoid criticisms, guilty, and comparisons. While parents may have the best intentions, this will only lower their child's self-esteem and ability to make good choices. To provide feedback, give 2 compliments for every 1 criticism. Be specific about the things they do that make you proud. We call this a compliment sandwich. So how can parents learn more about parenting? At the Family and Youth Institute, we specialize in providing parents with practical, research-based parenting techniques. Whether your child is in preschool, middle school, or high school, we have the resources for you. Our resources include interactive parenting workshops, free parenting articles, videos, infographics, and webinars. To learn more about our resources, visit our Facebook page and join our email list.
From the research to kind of simple steps that parents can understand no matter what their educational background is. If you look at the actual videos, we highlighted different levels of religiosity, different ethnic groups, and the idea is how do you be more inclusive, how do we provide the research, and give simple tips. But then immediately connect those simple tips to actual resources if you want to continue developing change. But what the videos is basically for your information. Did you know that this is going on and this is what you can do? And then connect them to these additional resources. And then we move to the next step within step 5, which is skills building. Okay, now that we've built awareness, we've then given them specific tools and ideas that they can implement at home, how do you bring it to the next level? How do you develop those skills? We talked about in the video, open communication. Well, what does that look like and how do you do that? And so these skills building workshops are available, again, for professionals, community leaders, parents, and youth to develop those skills that they need either to promote their youth development or for young people to really help promote their development. And so then these workshops are actually research-based and clinical-based and really integrate culturally and religiously relevant material, but then uses active learning concepts so that, and some of you attended the suicide training that we did yesterday, really taking the didactic component, the research component, presenting that information, then practicing that information, then going back and making sure that information is practical. And so we go through that process to help build skills. And then we have a number of resources to help Native American Muslim youth for those who really want to know more information. If you're a clinician, the Counseling Muslims book, as well as Arab American Psychotherapy book, and a number of different books that our team members have written to give them additional information to the clinicians. Or, for example, the daily articles, what we do is Monday through Friday, we provide articles for parents or for individuals that, maybe one day is kind of really focused on parent development, parent-child communication. Another is mental health literacy day, where different types of mental illnesses are highlighted and what are the different symptoms by age or by issue, and really providing that mental health literacy so that we can reduce the stigma and increase awareness. And then different toolkits about, digital parenting, bullying, all these different resources that provide in-depth information to kind of walk through an individual with no clinical background, no research background, and what can they actually do with that information. But then once you develop these programs, provide these skills, you want to know, are you having an impact? And really understand, is growth happening within the community, within the individuals? And then start having those evaluations for the programs. And so we look into quantitative and qualitative research methods in terms of understanding what is happening in our programs, really understanding how many people are we reaching with our resources. So for example, I think the infographics have reached more than 100,000 people. Then we know that, okay, the message is getting out there. Now we need to kind of follow it up with, okay, what are the resources, and do people know that these resources are available? And most of the resources are actually freely available, so that we can have that impact. And so we're kind of just entering this phase where we're kind of cleaning up our program evaluation component and really kind of measuring this. But that's kind of where we are in terms of really having that impact. And so we go back to this model of promoting youth development, understanding development, really trying to get to the different aspects of the intervention points, the partners, how can we really have that impact in promoting youth development through a more public health model. So again, we research, educate, empower individuals and communities, and then we evaluate, are we having the impact that we are, and are we truly promoting youth development? So I urge you and encourage you to follow us on social media to see how we're doing. I urge you to kind of look at this model that we have been implementing, and perhaps those of you who are running organizations consider that yourself. But at the same time, if you see things that could be improved, to really think about, well, what else do we need to be doing as a community to promote youth development? And what else could we be doing to enhance the impact for young people?
Attend Muslim Mental Health Conference.
Yes, attend Muslim Mental Health Conference. Be aware of what are the resources that are out there and amplify other people's work.